I'm asked to present some of these registries that Glenn was pointing out, the PedNeT Registry, and also to try together with you to think how we could work together in the future on data. Because we might, of course, data collection is a very intensive way. If you do it the right way, it's time-consuming. But I agree completely, without data, you can't support what you're doing. So it's really important. And we have been fortunate in Europe that we brought these minds together about more than 20 years ago and start collecting data. So what we decided that we want to have full cohorts. The reason for doing so is that in a rare disease like ours, that you quite easily get selection bias. By selection bias, what you get in clinical trials, you know, if a pup goes in a clinical trial, we often select the parents that are the most compliant, the people that are close to the hospital, and maybe not the one with the intracranial bleed of the problem. So we do select the patients. That means that the results later on of that clinical trial might not be applicable to the whole population where we are going to use new drugs. And that's even more true now than it was in the past. So we need really to address this on a different way. So that thinking brought us getting into full age cohorts, where we started from patients born after 2000 and 2009. Also to acknowledge the fact that in hemophilia, it's known as an inherited disease. We all agree about that. But we also have to recognize that in severe disease, the majority of the patients are not diagnosed at birth. The majority are diagnosed later on when they are bleeding. That has an impact on how the effect of treatment later on will be appreciated. So again, 2 cohorts. We decided not to collect data on very mild disease because we thought our attention was to collect data on patients that really needed coagulation products. So just as an idea, I think the power of data collection is not only to include your baselines, but to collect your data on your follow-up forms and have your new inclusion, but also follow-up on your patients. So what we do is that we follow up on all the patients that we have included until they're adults, and hopefully after that they will be followed also. And just to see over time, our cohort is increasing over time. So these were the last 3 years of data. And this is our last annual report, where we have registered in PedNet almost 2,000 patients. And I'm happy to say that we really now surpassed our 2,000, and that we have data on 1,083 patients, pups with severe hemophilia A, with very detailed data. And also 161 patients of hemophilia B, because we don't know too much about hemophilia B. It's a even rarer disease. So if you want to know more, you really have to do international research. So we work together with 33 centers, and then, in fact, there are almost the same centers over all these 20 years in 18 countries. We also collect data on gene defects. So we have almost 90% of detailed gene defects also available. That really makes it very interesting for research. And then, of course, what Glenn is also pointing out, long-term follow-up is crucial. So these are beneath our total number of follow-up, and this is growing, of course, every year. So some data just in general to see the power. These are the patients of severe, moderate, and mild hemophilia over time. These are our patients, our first complete cohort. And so, again, we have more than 60% of severe patients in our cohort. And these are the data for severe hemophilia B, where we also get new data also on immunogenicity. But in fact, PedNet has not been to look for immunogenicity. The reason we started it up, we were a group of pediatric hematologists, and we want to understand more about the natural history of the disease and a lot of things that are happening there. So we started as a disease registry, not as a product registry. Of course, we collect data on product, but it's the disease registry, that's the power of this. So this is not meant to go too much in details about this. This is just to see the growing number of patients over time. So it takes a while to get, it's a rare disease, so it's hard work. And this is over years, so this is for us as a group important because it shows how stable we are able to select all patients in the centers, and our monitors, they go there, they control informed consent, and they also control the baseline values, the source verification of the data, the diagnosis and everything. I think I really like this slide. I think we can continue to argue about the power of randomized controlled trial, and there is no any concern about how important that is, but we're working in a rare disease area. So we also have to collect data just below randomized controlled trial, see how we are able to get convincing a number of evidence. Randomized controlled trials are good, but they have also limitations. And I think we have to try to get more evidence on a lot of issues. And cohort studies like we have done is just a little bit under the power of randomized controlled trials. And quite often what we do in medicine is this is where we are happy. We showed safety and efficacy in this level, and then we stop. And in our field, that has been too much long, the occasion. And I really would like to encourage you that continuing data collection is very important. Again, a very important article for other people. We need to do observational study to look for comparative effectiveness. And that's not only in hemophilia, it's acknowledged in a lot of other disease areas. And just to compare the randomized controlled trials and the limitation, so we might have a selection of treatment, selection of testing, but we have much more a more homogeneous population. For a randomized controlled trial, you can also have a selection of patient. The setting, is that more comparable? Of course, homogeneous testing is more homogeneous, but there is also a lot of limitation, and long-term outcome can't be studied in a randomized controlled trial setting. And just again, I thought I put something in that you can appreciate a little bit what the effect is of the age of diagnosis on the start of treatment. These are three real examples taken from data from PedNet. So we have seen that more than 50% of the young boys that came into our registries have a negative family history for hemophilia at diagnosis. Then later on, of course, a second child might be born, but at the moment this was the case. And the children that had an early diagnosis, so they are here, they're starting to be treated with careful because we know they have hemophilia, we are concerned, we know what to do. But when we look in the children that were diagnosed because they had bleeding, they got a peak treatment at the moment of diagnosis because that's what we do. We diagnose because they are bleeding. And that has an impact on immunogenicity and might also have an impact on outcome. So if we're not going to collect these data, we don't know why one patient is doing worse from another patient. So that lifelong data collection is very important. How could we collaborate with the WBDR in the future? Some consideration. So we collect prospectively all newborns from diagnosis onwards. All these patients are now 18. We, of course, come from a different geographic, we have the opportunity from primary prophylaxis. But what we are lacking and what we would be interesting to collect, to compare our data on long-term outcome with other areas. So also for other geographic areas as an aspiration where you could go to, what is possible, what kind of activities is possible, what can all the children go to normal schools when they have low-dose prophylaxis? How does low-dose prophylaxis, the outcome of low-dose prophylaxis, can compare with what we think is the highest standard so far? And if we have the highest standard for us, even now with all the new possibilities, do we have to go and invest even more? Because price is an issue, and we have to think about healthcare budgets. And I think really the strength of the WBDR is that you get a worldwide coverage, and that we can try to think how we compare data. So, effect of primary prophylaxis versus secondary prophylaxis, I think is still very limited data on different parts of the world. I think it would be really interesting if we can collect that. Age at first joint bleed and severity of disease is something where we should try to collect. It's not difficult to do, but very important to do. Intracranial bleed. I was in our part of the world in severe hemophilia on prophylaxis. We don't see very frequently intracranial bleeds, but when we were traveling, when talking to colleagues, intracranial bleed is still very frequent. So it's important for advocacy. If we can establish these numbers, that the difference with good treatment, that you can prevent that, would be very important to establish. And of course, what I said, activity level, participation in school, and having a more normal life is something where we should collaborate. So this is the PedNet group, and this is the people working on this. Thank you.